basic clinical microbiology workflow, and the rapid molecular diagnostic tests. So we all understand that it is critical need for rapid and accurate organism identification as well as antimicrobial susceptibility testing. So when you collect a sample, to the extent that you receive your sensitivity report, what is the basic microbiology pathway? So, right from collection, the sample is transported to the lab receives it, processes it, then it is put to a stain, then to a culture, followed by detection, identification, sensitivity, and then the report is finally released to you. So, what does the basic clinical microbiology practice involve? It is basically that, when you're collecting a specimen, it should be the representative of the disease or the suspected part. So, whatever your underlying etiology is or whatever infection you're suspecting, that should be the sample that you should send. Whether it is blood, whether it is your sputum sample, patient's bronchoalveolar lavage, urine, cerebrospinal fluid, pus or wound swab, as well as the sterile fluids like the pleural or the ascitic fluid. So depending upon the site of infection, you send the appropriate sample. Now, once you've collected the sample, transporting the sample to the lab should be the goals of transport should be that you should preserve the organism viability, prevent overgrowth of contaminants, and the ideal is to immediately transport the sample to the lab. Some samples do require specific transport media, like the Carry-Blair media for the stool pathogens. So all this should be kept in mind while transporting the sample. Once the sample is received at the lab, ID'd and everything is labeled properly, the sample is processed. Now, for processing, the sputum sample it is put to gram stain and culture. Urine is for semi-quantitative culture. Blood, whether automated or manual incubation, and pus is directly plated. Now, what is the importance of gram staining? Gram staining, when your microbiologist tells you that is growing a gram positive or a gram negative bug, that actually helps you to further guide your empiric therapy in your ICU. This is very important and crucial for your critically ill patients. So, two distinct pathways are currently in place in India. One is the manual methods, which are mostly in the government setups, and semi to fully automated systems for culture as well as sensitivity in private sector hospitals and even in the tertiary care centers. Now, what are these? Manual is basically a technologist reads the growth, subcultures the plates, and interprets reactions visually. Semi-automated systems include basically involves instrument that assists with incubation, reading, or inoculum standardization, but some manual steps still remain in the process. Now, fully automated systems, right from loading of the specimen to incubation, detection, reading, interpretation, and data transfer are all instrument driven. They're all fully automated. In practice, most of the labs, even the lab in our hospital at Apollo Delhi, we follow the hybrid model. So that basically is that automated blood culture, automated or semi-automated identification and antibiotic susceptibility testing, and manual confirmation when needed. So most of the places which have automated systems usually follow this hybrid model. Now let's look at the manual methods first. So once you have a sample, which is sent to the lab, it is first inoculated on the culture media. Depending upon the purpose, the specific agar is used, whether it is blood agar, McConkey agar, chocolate agar, which are the commonly used agars in the microbiology lab. Now, once the sample is inoculated, it is incubated at a temperature of 35 to 37 degrees Celsius. Each of these bacteria, they require a specific atmosphere like aerobic, anaerobic, or CO2 enriched media. And the time frames for incubation for routine is usually 18 to 24 hours, about 48 to 72 hours for slow growing organisms, and specialized cultures takes weeks. For example, we receive the TB culture reports after 6 weeks. So once your organism is grown, it requires identification, which is based on the colony morphology, the gram stain, and the various biochemical tests that are available. Once the organism is identified, then further antibiotic susceptibility testing is done. The most common used method is the Carbapenemase disc diffusion method, which is based on the principle of zone of inhibition. And the interpretation is based on the CLSI and the UCAS standards. And we often receive our reports as sensitive, resistant, and intermediate sensitive. Now, there are various antibiotic susceptibility testing and giving the MIC. Various methods are there. Broth microdilution remains the gold standard. There is also broth macrodilution, agar dilution. Very often, the gradient diffusion and e-tests are used. Then there are automated MIC systems like the commonly available one is the Vitek 2, then the others like Phoenix, Microscan, and the Sensititer. Then there are also rapid phenotypic antibiotic susceptibility testing method. So how does MIC help? What is the significance in ICU? It will help you in your dose optimization, identifying your MDR pathogens, and then for the PK/PD targeting. So that is what is the relevance of MIC in the ICU. Now, after looking at the manual methods, let's understand what are the semi to fully automated systems for culture and the sensitivity testing. So once you have a blood culture, how is the blood culture processed in a lab? First of all, remember that always collect a blood culture in a pair. It should be one set, which should include an aerobic and an anaerobic culture. Minimum 10 ml of sample should be sent. And once, the most important, always teach your staff, nursing staff, and your paramedical staff who are taking care of the patients to always, collect these cultures with full aseptic precautions. Once you've collected and you send these blood culture bottles to the labs after receiving them. Now, since we are talking about the automated system, this is one of the automated systems, which is the BACTEC Alert Virtuo system. This is the latest BACTEC Alert Virtuo system which is used. So once the lab receives this, they are loaded onto this machine and they are incubated at 35 to 37 degree Celsius. And these bottles are monitored by the machine every few minutes. Once there is a positive signal which reflects on the screen, the bottle is removed. Immediately in the lab, then it is put to a gram stain. This is followed by a subculture on appropriate media. Once the subculture starts to show the colony growth, then it is put into the Vitek 2 for identification and sensitivity, which is a fully integrated system. It uses self-contained disposable cards and automated interpretation. It delivers fast routine AST and MIC based or categorical output depending on card and organism. And it basically, improves the workflow efficiency and has a broad clinical utility. So what happens in Vitek 2? You have a colony that was grown on your culture media. Then the fresh colony is picked up and a pure isolate is taken. This is then the inoculum is standardized to a defined turbidity or instrument verified density. Then the organism suspension is loaded into the cards, panels or wells containing antibiotics. Then the instrument incubates and reads growth signals over time, and the software converts the pattern into identification and susceptibility results. So again, to summarize, you have a blood sample. The blood sample is put into the Virtuo machine for detection. Once there is a positive signal, it is taken and an immediate gram stain is done and it is subcultured for a colony. Once there is a colony growth, it is again further processed, put into the Vitek for identification and sensitivity. And this is the workflow that gives you the final culture sensitivity report. Now, apart from blood, there are other samples like sputum, bile, urine, CSF, pus. So again, a very similar pattern for the other samples as well. You have to first gram stain, you must. And then of course, the culture is put. Then again, it is processed after the colony grows on the culture media. It is processed, put into the Vitek 2 for identification and sensitivity, and then it gives you the final report. So similar workflow action is done for the rest of the samples apart from the blood. Now, another method for identification of the microorganisms is the MALDI-TOF method. And this is the latest Vitek MS Prime, which is available in a few centers. Now, how does the MALDI-TOF mass spectrometry method work? It identifies organisms by protein spectral fingerprint. So it works from colonies and sometimes positive blood culture material. It is useful for identifying all bacteria, yeast, anaerobes, selected mycobacteria as well. But remember, it requires a growth or a positive culture material. So it does speed your identification, but it does not give you the antibiotic susceptibility testing. So that's what determines the drug choice. So this is the Vitek MS 3.2. Like I said, once the growth is there on the colony plate, it is taken onto the target plate. Then the target plate is inserted into the Vitek MS 3.2 system. Then the machine has laser ionization, does the laser ionization of the sample, and a spectra is generated within seconds. Now, what is this spectra? So, MALDI-TOF basically has reference spectrums within for each organism. And when your sample matches the when your sample spectrum matches the reference spectrum, that is when it gives the identification of the particular organism. And that is how the bacteria or the microorganism is basically identified by MALDI-TOF. So as you can see, with the manual pathways, it can take up to 72 hours before you get the final report. But with automated pathways like MALDI-TOF, it can actually identify organisms as early as 5 minutes, and Virtuo can flag growth anywhere between 6 to 11 hours. So it basically saves time for your targeted therapy, hence improves the overall outcome. So when we look at the microbiology workflow, manual processing is tedious. It takes prolonged time. There's a lot of manual labor that is involved. And ultimately, it takes about minimum 72 hours. Whereas the latest automated systems, the Virtuo, the Vitek 2, the MALDI-TOF, they can give you results as early as 8 hours. And within 24 hours, you have the full antibiotic susceptibility report. Now, after the basic microbiology workflow, let's look at the rapid molecular diagnostic tests that we were told by Dr. Ram Gopalakrishnan in the last lecture. So, a rapid molecular diagnostic test basically is a test that gives you clinically actionable microbiological information faster than the standard culture. And rapid does not mean definitive. Remember that, because many platforms detect DNA and RNA and not the viable organism. So it is a part of the clinical decision pathway. Now, why do these matter? Why do rapid diagnostic matter in your ICU? Because earlier pathogen identification and resistance detection, timely escalation for MDR organisms, and safe de-escalation when key pathogens are absent. It is valuable only when it changes a real ICU decision. So you need to really know when to send and how to interpret these rapid diagnostic tests. How are these rapid diagnostic tests different from the conventional culture? A conventional culture would detect a viable organism, but a rapid molecular test would detect nucleic acid. A conventional culture would give full susceptibility after the growth, but a rapid molecular test is limited to resistance markers. Now, a conventional culture would grow any organism, but the rapid molecular test would only show you the targets that are present on that particular panel, the particular molecular test that you're doing. Conventional culture takes time. It is anywhere between 24 to 72 hours or even more. But a rapid molecular test can give you results as early as 45 minutes. Prior antibiotics will reduce your yield on your conventional culture. For a rapid molecular test, often is still positive even with prior antibiotic use. So remember that a PCR complements a culture. It does not replace a culture. Now, whenever you are sending a test, you should always have something in mind that if it comes positive or negative, is it going to change my management? Just because a rapid molecular test is available and it is going to give you results fast does not mean you always have to send it. So every test should be properly thought of. Now, molecular tests detect nucleic acid, not always live organisms, like I said. So these tests basically accelerate the decision making, but culture and AST remain the essential for final confirmation and antibiotic optimization. Various molecular rapid tests are available, and they are identified and classified by different technology. For example, we commonly use the singleplex PCR, RT-PCR, like our COVID RT-PCR or H1N1 PCR. So they detect the DNA or RNA of one pathogen. So it confirms a specific suspected infection quickly. Similarly, we have the multiplex PCR, wherein there are many organisms in one test. Like we send our upper respiratory nasopharyngeal swab for respiratory viral panel. Now, these are useful when many pathogens can cause the same syndrome. Syndromic molecular panel, which are based on the clinical syndrome. And like your lower respiratory pneumonia panel or your BCID panel, meningitis encephalitis panel, or the GI panel. And these will help you to, understand the etiology for your pneumonia, sepsis, meningitis, or even diarrhea. Then we also have the cartridge-based nucleic acid amplification tests. Now, these basically detect the pathogen DNA, RNA, and also the resistance mutation. Like we commonly send the gene expert for our MTB, Mycobacterium tuberculosis samples, and the Xpert Carba-R. Then there is real-time quantitative PCR. Now, this basically determines the viral load or the semi-quantitative pathogen load. Like we send the CMV DNA. Now, this will help in judging the severity. This is very useful in your transplant patients, immunocompromised hosts, for monitoring, and also for differentiating between the colonization and the infection. So there are various molecular tests that are available, and we are going to be emphasizing on the multiplex PCR and the syndromic molecular panels. So let's look at these. Now, the FilmArray multiplex system. This is the fastest path to improve the turnaround time in critical care settings. And this is the FilmArray BioFire system. And as you can see, it is a fully automated system. You prepare the sample, and once it is put into the machine, it is extracted, amplified, and it is detected by the machine, and the machine gives you the results. So BioFire FilmArray is a syndromic multiplex PCR platform. Syndromic means that instead of testing for one organism at a time, it tests a group of likely organisms causing the same clinical syndrome, such as pneumonia, respiratory infection, sepsis, meningitis, and gastroenteritis. Now, how does it work? There is a FilmArray pouch. Okay, so this is all automated. The sample is put on to this in this pouch, and once the sample is, this is a fully automated system. This uh, the machine does the job. So basically, it is then extracted, amplified, and then with first stage multiplex PCR, second stage PCR, it gives you the result. And 2 out of 3 wells must be positive. All this is automated. All the results and analysis are done by the machine. They're all automatic. So the BioFire panels that we commonly use is the respiratory panel, which is sent with a nasopharyngeal swab. So remember, this is your upper respiratory panel. The pneumonia panel or the pneumonia plus panel are your lower respiratory tract secretions like sputum, endotracheal aspirate, your bronchoalveolar lavage, mini bile. Then the BCID2 panel, which is in a positive blood culture bottle. Meningitis encephalitis panel, wherein we send the CSF. And then the GI panel, wherein the stool is sent in the Kerry-Blair medium. So we'll be looking at each of these panels, starting with the BCID BioFire panel. So, blood culture remains central in ICU sepsis, and rapid blood culture panels accelerate action after the bottle becomes positive. This is important. They do not replace the collection quality. So once you have a rapid ID, once the blood culture flags positive, the organism can be identified on the same day by a gram stain, by MALDI-TOF, like we just discussed, rapid multiplex PCR, FilmArray blood culture ID panel, and Xpert Carba-R, which was initially designed for stool, but there is some off-label use for blood as well. So this is the rapid BioFire blood culture identification panel. As you can see, there are 27 pathogens, gram-positive, gram-negative bacteria, fungi, as well as the resistance. Then this is the BCID2 panel, which is more widely used. This has 43 targets. The turnaround time is about 1 hour. It also includes Candida species like the Candida auris and the Cryptococcus neoformis. Resistance genes like CTXM, KPC, NDM, VIM, IMP, and OXA48 like, as well as the MCR1. Now, once you've done this, how do you interpret this? So, your result would be Staphylococcus aureus with the MEK gene absent. So this tells you that the most likely infection is MSSA. So, if you've already started your patient on vancomycin, you can de-escalate and you can use an anti-staph beta-lactam. Similarly, if the report shows an E faecium with VAN A, VAN B, so then it means that is VRE likely. And depending upon the syndrome, you can choose an appropriate gram-positive cover. Then a Klebsiella with CTXM. So this tells you that it's most likely ESBL. So carbapenem is often the preferred drug of choice. Enterobacterials with NDM, so metallobeta-lactamase, CRE. So again, ceftazidime, avibactam, and astronam become your drug of choice. If it flags a Candida auris, then firstly, this tells you that you require a high infection control. You need isolation and contact precaution. And of course, high-dose echinocandins remain the drug of choice. Remember, this should trigger a stewardship, not a chart update. Then, when you're doing molecular testing for your bloodstream infections, what are the advantages? It will reduce the mortality when it's combined with AST, and it will give same day information for the identification and DST in critically ill patients. The only important point you need to remember is that it needs a positive blood culture. So, that should always be remembered. Why I'm saying is because there are a lot of PCR panels these days, which say that you can directly do the PCR panel with the blood, which is not FDA approved and should not be done because it has a very poor sensitivity and specificity. So now let's look at the upper respiratory throat swab nasopharyngeal BioFire assay. Now the options in these are individual PCRs, multiplex PCRs, and FilmArray panel. Now, these are important because molecular tests, when they are preferred, when you're missing the diagnosis, it would change your isolation as well as therapy. So that is how these are beneficial. And remember that these are the upper respiratory panel wherein you send a nasopharyngeal swab for your patient. This is different from the lower respiratory panel. So this is the throat swab BioFire assay which is available, wherein you send the nasopharyngeal swab, 15 targets, gives results as early as 15 minutes. Some pitfalls that you should remember: it may not be the true pathogen, rather may be causing an asymptomatic infection or bronchitis. So you must always, this is always, correlate clinically along with the radiological picture. It may not be the only pathogen, may not allow de-escalation as secondary bacterial infections are possible, and it does not include Legionella and tropical pathogens like scrub typhus and leptospira. So this is for your upper respiratory panel. Now, the lower respiratory tract infection panel. So, you must confirm the syndrome, clinical and radiology. This is always essential. Collect the sample, whether it is your sputum, endotracheal aspirates, BAL. Always do a gram stain and culture. Do not skip this. And then, of course, appropriately add the PCR panel. And, then act and reassess. Again, correlate clinically, and you should always review your patient's drug charts daily for de-escalation. And remember that this is the lower respiratory tract panel. This is the lower respiratory tract pneumonia panel. So this basically again has a turnaround time of as early as 1 hour, 33 targets, 15 semi-quantitative bacterial targets, and 7 major resistance gene groups. This is the BioFire FilmArray pneumonia plus panel, which has these bacteria, antibiotic resistance genes, atypical bacteria, and the viruses as well. Now, in the pneumonia plus panel, it does not have COVID, so you have to send this separately. Legionella is included, but it again does not include tropical pathogens like scrub typhus and leptospira, and has many normal colonizers of the respiratory tree when used for community-acquired pneumonia. So it's primarily useful in excluding a bacterial etiology for community-acquired pneumonia. Then these are the bacterial targets of the BioFire pneumonia panel, the gram-negative, the gram-positive targets. And when these PCR tests are done, when this pneumonia panel is done, the results, the PCR results are they are given semi-quantitative sometimes. So, you must always remember and interpret this along with the burden, the organism, the specimen, and the patient together. For example, it flags 10 to power 4 copies per ml. So there can be a possibility of colonization, early infection even, or partially treated infection. So always correlate carefully and do not automatically start treating because certain copies have been shown on your PCR results. Again, similarly, 10 raised to power 6 or 7 copies per ml. So more supportive of true infection. Treat if the compatible syndrome and sample quality also. So you must remember all this, always correlate clinically before just looking at the report and jumping onto treatment. Now, we were just talking about the pneumonia panel. So these are the viral, atypical, and resistance targets that the BioFire pneumonia panel tests. And the limitations of this pneumonia PCR panel is that colonization is common in ventilated patients. Poor sample quality misleads both PCR and culture. Multiple detections can confuse therapy. So never treat the panel. Always treat your patient. Always correlate clinically. A lot of times we get carbapenemase resistance. So there are a lot of rapid tests which are available to detect it, like the Carba-NP, the lateral flow immunoassay, the PCR syndromic panel, and even sequencing. So this is just to show you quickly that this is a lateral flow immunochromatographic assay. And what it does is it is used for detection and identification of carbapenemases. We just talked about this OXA48, KPC, NDM, VIM, and IMP in the bacterial culture from a bacterial colony on an agar plate of blood culture. So you've sent this, you've got the result. How would you interpret it? For example, if you get KPC as the mechanism detected for resistance, so then the therapeutic implication implies that you can give ceftazidime avibactam or meropenem viborbactam as your drug. Then similarly for NDM, VIM or IMP, you can consider astronam and avibactam as a strategy. For OXA48, like ceftazidime, avibactam are often enough for this. Cefderichol can be used as an alternative. If no carbapenemase gene is detected, you should always remember that the resistance can also occur through different, like the loss of porin channels or through ESBL and AMC. So do not assume just by looking at this that the organism is susceptible. Similarly, we have the meningitis encephalitis panel, and these are the regular tests that we do on the CSF sample. We also have the BioFire for this encephalitis meningitis. We had an herpes patient with herpes simplex, and with timely treatment with acyclovir really improved the outcome in the patient. So these panels really become helpful in such circumstances. Similarly, we have the gastrointestinal panel, which has 22 pathogens. And if you have a patient with Vibrio cholerae, important is to isolate and proper handling of the patient, as well as the all the secretions and samples of the patient, and timely treatment can really improve the outcome. So these panels do help, but it always should be correlated clinically. So rapid tests are more powerful when they are paired with people and protocols. So just to summarize, from sample to sensitivity, every step matters. The quality of microbiology starts with the right specimen from the right side. Poor sample collection can lead to wrong diagnosis, contamination, or missed infection. Culture remains essential because it gives you the viable organism and enables definitive AST and MIC. Grandstand gives the first rapid clue, but final treatment should be guided by identification, susceptibility, and clinical context always. Timely reporting of identification and AST always helps in better outcomes. So remember, correct specimen, correct organism, correct antibiotic, improved outcome. For rapid diagnostic tests, they shorten the time to action, but they do not replace judgment. They help to identify pathogens and resistance markers within hours. They are useful when the result changes the management. Molecular tests detect DNA and RNA. So positive test result may represent infection, colonization, or residual nucleic acid. So you have to correlate. Culture and phenotypic AST are still needed for full susceptibility and confirmation. And rapid diagnostics, they work best when there is a clinical correlation, sample quality, culture, and stewardship review. So do not treat the test report alone. Treat the patient as a whole. Thank you.